All right, everyone, let's kick us off. It's 11:33. Welcome to the October 2025 Community Health Advisory Council meeting. I have a script now, so that I make sure I say the right things consistently before every meeting. So here goes. The Community Health Advisory Council is established in Oregon law and instituted locally here in Crook County. The Community Health Advisory Council provides recommendations to the Crook County Board of Commissioners regarding public health and behavioral health services and issues. These meetings are an important opportunity for partners in the community to work collaboratively to support the health and safety of Crook County. Please note this is a public meeting. However, there's no public comment period and members of the public may not speak during agenda items. If you're a member of the media or general public and have questions or comments, we ask that you reach out directly to a Community Health Advisory Council member or a staff member outside of this meeting. We'll begin today with a roll call of our appointed members. When you're called, please share your name, role, and organization if applicable. And then after roll call, we'll invite staff members to introduce themselves as well. So I'm getting my list of folks. And I will start with Courtney.
What's that, Courtney? I'm here. Courtney Peressa, physical therapist at St. Charles Prineville, but I think I'm just a community member on the advisory board.
Thank you, Courtney. My name is Katie Plum. I'm the Health and Human Services Director for Crook County, and I serve as chair of this group. Erica. I do not believe.
I don't think Erica is here.
Hope.
Nope.
You said would not be here today. April. Is she able to join us?
She's not here at the moment either.
Bill.
Also not here at the moment.
Kimberly.
This is Kimberly. I'm here.
Hi, Kimberly.
I'm the chief nursing officer.
I'm sad we're not in the same space.
That's okay. There's food here if anyone wants to come this way and grab a sandwich.
We'll make it round.
Feel like an idiot. I'm sorry.
That's okay. I'm the chief nursing officer at St. Charles over Prineville and Madras.
Thank you, Liddell.
Hi, I'm Liddell Harris, and I'm an autism mouse.
Welcome. And Devin.
Devin Nelson Harmon, community organizer for Crook County for NAMI Central Oregon. And I do apologize, I cannot stay for the entire meeting, but I'll be here for the first 15 minutes or so. I had a family emergency.
Okay, thank you, Devin. We will work to get our agenda items that we're voting on in front of you so that you can participate before having to go.
Perfect, thank you.
All right, with that in mind, we will do some shuffling. So to start with, the August 4th meeting minutes were sent out. Oh shoot, I forgot staff introductions. I'm so sorry. Let's do staff introductions. I was getting after it. Angela, do you want to start? Try to find somebody without their mouth.
I'm the program director for Best Care in Crook County, or the CMHP.
Mike Case, program manager for the Intellectual and Developmental Disabilities Program for Crook County, contracted for by Best Care.
See you in person.
I'm sorry. Excuse me. My name is Riley Martin. I am the Public Health Emergency Preparedness and Response Coordinator for the County Health and Human Services.
Hi everyone, I'm Haley Morris and I'm the Overdose Prevention Coordinator for Central Oregon.
And I'm Alex Greenberg. I'm the Mental Health and Suicide Prevention Coordinator at the Health Department and the staff that helps run these meetings.
I'm Stephanie O'Neill. I'm the Public Health Modernization Manager and Prevention Health Promotion Supervisor at the Crook County Health and Human Services.
All right, thank you. We're going to skip over staff and member announcements, probably bump those towards the end of the agenda. So that we can take action on anything that needs a vote. The first thing that needs a vote is our August 4th meeting minutes that went out in the agenda packet for review. And I would entertain any discussion, if there's anything misrepresented, misspelled, that you want amended. If not, I would entertain a motion. Reminder that appointed members are those who can motion. So I'll make a motion if someone would like to say. Thank you for clarifying what I was mentioning and what you're seconding. Is there anyone opposed to approving our August minutes? Is there anyone who would like to abstain?
I need to hear each person's yay or nay, technically. Or public law.
Devin says yay.
Okay,
Courtney and Kimberly say yay.
okay. Liddell,
Liddell seconded,
do you yay?
yes.
And Katie? Okay, thank you.
Okay, August 4th, meeting minutes have been approved. Next topic that we are voting on is we have member applications for us to review and provide recommendations to the Board of Commissioners for appointment. The first, it looks like, is Emily has joined. us
Emily's on the meeting,
today.
yes.
So let's start with Emily. Emily is working for the Prineville Police Department as a mental health officer. Has anyone not had a chance to review their application? Everyone's taking a look.
This is just appointed people, right?
These are folks who are applying. Oh, yes,
Okay.
yes. Is there anyone who would like to provide comment on Emily's application?
That looked good to me.
I think it's good for us to have representation with or from Prineville Police Department. And the fact that she's a mental health officer, I think is great. Brings great
It's
perspective.
not working, I can't. Stupid.
Goodness, Emily has a master's degree in psychology and is in progress of obtaining her master of clinical social work. Impressive. I hope you are able to sleep. A lot to take on. Is there any additional discussion on Emily's application before we move to vote on a recommendation to our Board of County Commissioners for appointment?
Anything from you three online?
No, I'm just excited to have you here, Emily.
We agree here in Prineville.
Excellent. The motion to recommend Emily's appointment by the Board of Commissioners.
The emotional second.
I will, this is Courtney. I will make the motion to appoint Emily to the Community Health Advisory Board.
And this is Kimberly. I will second.
Oh, Thank you. Like you all are working on tandem over there. Any additional discussion? Anyone abstaining? Anyone opposed? All in favor?
Katie,
Aye.
Liddell, Courtney,
Yes.
Kim,
Yes.
Devin,
Yes.
perfect, done.
Next up is, Mr. Grant Ball, who is currently the Director of Special Education for Crook County School District. And what else? And everyone else paused. I hope that doesn't mean you're abstaining, but.
No.
Any discussion regarding Grant's application?
He's a really, really nice man. He really is.
And a great connection within our school district, I think. I think it's important that we have folks in all levels of leadership in the organizations that are represented here, so I think that would be an excellent, that would be a great addition. Is there any additional discussion from folks online?
Looks like no. Oh,
All right, I think motion.
How do I say this?
Well, go ahead and we can wordsmith it if needed.
Okay. I nominate her for Grant to be, on our team.
Liddell has
Yeah.
made a motion to recommend Grant for appointment by our Board of Commissioners. Is there a second?
This is Courtney. I will second.
Courtney, any additional discussion? Any abstentions?
Katie,
Opposed?
Katie,
Yeah.
Liddell, Courtney,
Yes.
Kim,
Yes.
Devin,
Yes.
perfect, done.
We're on the home stretch, folks. Jumping through the hoops. Our third applicant, we have 4 total, which is really exciting to have this much interest. Our fourth applicant is Rita Roden, who is currently the perinatal care coordinator at Crook County Health Department. Is a Crook County native and has background in multiple aspects of health and wellness. Is there any other questions or comment on Rita's application?
She's like a bodybuilder, right?
A massage therapist. I don't think
Yeah.
she does bodybuilding, at least not anymore.
Not anymore.
It's been a while if she has. Well, hello, girl.
She is a, oh yes, personal training. She
trainer.
does personal
That's what it
training
is,
yeah.
and nutrition.
Cause she used to bodybuild and used to do like a lot of these shows, right?
I think she did
Yeah,
a long time.
she was really good at it. Yeah. I wasn't saying like it was a bad.
Yeah, no, no.
Good
I
at
just
it,
don't think
yeah.
she does that currently.
Mhm.
All right, any questions or comments on Rita's application? I think one thing I'll bring up is this group does provide oversight and guidance for public health. Uh, related programs and activities, and Rita is works for the health department, which there's nothing in our bylaws that prevents that. I just want to make it known. But that's the case.
Thank you.
All right, I'll take a motion. And we do have another appointed member joining us. April has joined us here in the room.
I guess I'm gonna share the screen with you guys.
Bouncing from meeting to meeting.
I'll nominate. I know. Thank you for our,
Lordell for the motion. Do I have a second? Recommending Rita, the Board of Commissioners.
Or not Rita anymore, sorry.
I think she still goes by
It's
Rita.
just a letter. I'll second.
Approve, motion, has been made and seconded. Any additional discussion? Any abstaining? Any opposed? All right, Alex.
Katie,
Yes.
Liddell.
Yep.
Courtney,
Yes.
Kim,
Yes.
Devin,
Yes.
April,
We have
and
Erica.
Erica. Did you hear all of that?
Most of it.
Do you yay or nay Rita, Rhoda, and Bean and Jack?
Yes.
Okay, perfect.
All right, last one, folks. Our final applicant is Tom Evans. He's currently the Veteran Service Officer for Crook County. And he's on all kinds of panels and committees and organizations representing veterans in Central Oregon and specifically in Crook County. Is there any discussion or questions about Tom's application for appointment?
Well, I know I'm not an appointed member, but Tom has a really great veterans perspective for the community, so I think he'd be a really good addition to the elected members.
It is a representation of a population that we don't currently have solely dedicated to for our veterans, so that is also something that stands out to me.
Sorry, Erica.
Erica, are you not hearing us? Okay, I will project. Is that
I can hear when Alex talks and when you talk, but in the room, like I can tell if there's somebody talking, but
okay? We will. I think what might be helpful if we're talking in the room, announce, like, state your name and then use our outside voices.
Oh, and I have my thing set to blur everything.
Oh, okay, I've lost my place where I'm at. I would entertain a motion regarding Tom's application. And if no motion, there's additional discussion.
I'll motion to approve. Sounds like a good representation of a group that we don't have yet. So motion to approve.
Thank you, Devin. Do I have a second?
I'll second the motion.
Liddell seconding. Any additional discussion? Any abstentions? Nays? Alex, you're up.
Okay, hold on, sorry. Katie, Liddell, Courtney,
Yes.
Kim,
Yes.
Devin,
Yes.
April,
Yes.
Erica.
Yes.
Okay, perfect. Thank you.
I don't believe that we have anything else on the agenda for voting.
No,
Does that sound right, Alex?
correct.
All right. So let's do, if it's all right. Well, if it's all right, I'm gonna move announcements, staff and member announcements to the bottom so that we get through our content today. First up is Angela, if you're ready. Sure. An overview of the CMHP, and you have a plan. that you've been
Yeah.
working on.
Yeah, so it's done, it's 27 pages. So the contracting with OHA is looking different for all the CMHPs now. This is actually a big to-do. Because none of the CMHPs in the state were happy with the new contracting process. However, the governor said, this is what we're doing, so previously, and if you've been in this group for a long time, you know that there have been the specific service elements that like I've talked about. Where what happens is we get funding in these specific service element areas. And then there are areas in this, that are in the big contract that we've never gotten money for. So for example, like ACT, assertive community treatment, we have never gotten money for that. And until a year or two ago, we never got money for civil commitment, but those are things that we are required to be doing. So now, instead of service elements, all the CMHPs are gonna be getting a chunk of money, and I don't know yet what our chunk is gonna be. We had to submit a budget and our plan to the state last week. And then they'll be working with all the CMHPs on their plans. And then everything needs to be finalized before the end of the year because the new contracts will go into effect January 1st. So there's these priority populations, and then it's up to us to sort of determine how that funding is going to be utilized. So there was this big, answer all these questions, and I'm not gonna bore everybody with all of it. Like some of it's just like, hey, give us an overview of what kind of services you have and describe your goals in collaboration with these entities. So it's like the local mental health authority, the CCO, community hospital, the courts, law enforcement, schools. So all of these different agencies, what does your, relationship sort of look like with them? And then we get into the description of the core service areas. So the way that the new contract is set up is it says you must do X, Y, Z. And then if there is available funding, then you can do this. And that's what the majority of the CMHPs in the state had a problem with because it was leaving it open to if there are available funds. And there's a lot of services that all of the CMHPs do that there's never enough funding for. So there is obviously the concern in that. We're not as concerned about it in the small counties, but like the bigger counties like Multnomah are very concerned about how that's going to impact them. I don't really think it's going to impact us too much. And in a way, the one good thing is that we can move the money to where we need it. And like I said, we've never gotten money before for ACT, but we have an ACT team and we have ACT clients who we do not get reimbursed for their services from the CCO because they don't have Medicaid, they have Medicare, and Medicare does not pay out for the ACT code. So we actually have these ACT clients that we're providing essentially free service for because we don't have funding for them. And so now we can, I'm just using that as an example. So now we can take from a bucket that maybe we've never fully used and sort of put it towards these ACT folks. So the core service areas are that we have to have system management and coordination. Essentially, that's talking about the administrative component to it. So obviously, I don't bring in money to the CMHP. I've run the place. I've got admin at the front desk who don't bring in money, right? So it's taking into account those kind of positions. And also the protective services. So we do the adult abuse investigations for the county. Can you guys online hear me? Okay, I'm loud, so but that's not an issue. So we've got the the protective services piece through that. And then there's crisis services, which isn't a problem. I mean, we've been doing we've been doing the adult abuse investigations this whole time too. That's also something we never get money for. Like, we've never got money for it. We were just expected to do it, but there's been no money for it. So now we can potentially put money into that bucket. Except essentially we're robbing Peter to pay Paul. We're pulling from a different program and putting money over here. And I won't know what our money looks like I said, until this plan gets finalized with OHA. I should say that the IDD abuse reporting, though, is done through Deschutes County or our county. So we contract with them. So we just do the adult abuse investigations for mental health. And then crisis services, we had to kind of map out what our crisis program looks like. We do the 24/7, 365 days a year, mobile crisis. We do contacts with people afterwards. Lines for Life is the contracted after hours line, if they can de-escalate over the phone. And then I go into the MRSS services, which is the stabilization services for youth and families. And I mean, I can go more into all of this, but there's a lot to share. So if anyone wants specifics, I can give that to you. So we're still in the core service area. So then there is the forensic and involuntary services. So that includes aid and assist, PSRB, civil commitment, and forensic diversion. That's fine. We've already been doing all of those things. We've actually only ever gotten a very small chunk of money for aid and assist, and have done more for, more services than what we have gotten paid for. So once again, we'll rob Peter to pay Paul. But we have to do the aid and assist. Nothing is changing with regard to what that process looks like. Other than aid and assist is just a mess in the state. PSRB, for those of you who are not familiar with PSRB, somebody has a severe and persistent mental illness and they commit a crime and they choose, or their attorney encourages them to go guilty except for insanity. What happens is, rather than prison time, the person goes under the jurisdiction of the PSRB for whatever the maximum prison sentence would be. So we have only ever had one PSRB individual in our community. He's no longer under the PSRB, but he was. So we don't have anybody else right now. But I mean, it's possible that we would see more. So there's a lot of things that are required for PSRB monitoring that is not like that the CCO doesn't pay for, right? So I mean, obviously any of the mental health services that are being provided, if the person has Medicaid, then it's covered. But all of the things that have to go to PSRB and things that they require that are not covered, we've never really gotten money for that before. So, but it sounds like that's going to potentially be more of an invoiced thing as opposed to coming out of the chunk. We're all still figuring this out as we go, just so you know. So if it sounds confusing, it's because we're confused. So but we're doing the best we can. We haven't gotten feedback on our thing yet. Civil commitment, we've already been doing the civil commitments. So that's nothing's changing there. We did start to get some funding for that because initially when we took over as the CMHP, that first year we had maybe like 10 civil commitment investigations, and we're already up to 64 this year, and we're not even at the end of the year yet. So every year we've seen more and more and more of those grow, and there will be a change in the law that goes into effect, I believe it's the new year, where it's possible that we will see even more of the civil commitment investigations going to trial. So previously it used to be if somebody was voluntary for services, then you could not take it to trial because you can't civilly commit somebody who's willing to do it. However, there is a pattern that's sort of been noticed that folks will say, I'll do it, and then they don't follow through. And so the change in the law, which Melissa Thompson, our chief behavioral health officer, was actually part of the work group to get the law changed, is that it's going to be less of a burden of proof to kind of like more will be able to go to trial without, like, you can disregard that piece if the person has this pattern of showing I'm going to, but then don't. So it's gonna be a huge shift. I know it's gonna be a huge shift for the hospital and the doctors and how they think about holds. It's gonna be a shift for us because we've only gone to trial probably 5 or 6 times total. So it's gonna be interesting to see how that all ends up playing out. But there's pre-commitment services, which is the initial investigation. And then there's placement and post-commitment services that we're responsible for if this actually goes to trial and the person's committed. So this kind of maps out what we do.
How many folks who work on that specifically?
So I don't have anybody whose job is like 100%. So Kate, our intensive services manager, she's the one who primarily does our investigations. And then Amy, who is our adult services supervisor, she's trained as a backup. And then one of our clinicians is trained as a backup to the backup. And then we're getting 2 more clinicians trained just so that we have multiple. Because there was just a couple weeks ago, Amy and Kate were both out, and we got 4 commitments in one day that our clinician then had to cancel all of his people to be able to go begin the investigations. We don't have, and we'll see if indeed the change in law results in us seeing more and more. It's possible I'll need a dedicated person for that. But we have created a position that we're trying to fill. That's a forensic clinician position that will be a person primarily doing civil commitment, but also aid and assist and responsible for the PSRB stuff. So it'll kind of be all in one, but we don't have a need for a dedicated civil commitment investigator, kind of like Deschutes County does. And then there's the forensic diversion part. So we're still under core services. This is the involuntary piece. And so, excuse me, I have a piece of spinach, sorry. So this is same thing, SPMI individuals. We've got a dedicated jail liaison who works with folks and a forensic, a certified forensic peer specialist. And so she's recently certified with that. And so we're figuring out how to kind of move her in with some of the jail stuff. So this goes into jail things. And also the wellness court, previously called mental health court. So we do that as well. So then another core service is the outpatient and community-based services. And in that, it outlines specifically what we have to do. So one is ESA, which is Early Assessment and Support Alliance. We actually do not do ESA here. That again is contracted with Deschutes County. That's for young individuals who've experienced their first psychotic break. And so it's a very intense model, similar to ACT for adults, but it's for youth or very young adults. And we don't have enough of them to have a whole team. So ESA comes out to Prineville and we give them office space. And so we're meeting that. We're just not the person providing it. Regular outpatient services, which I outlined what that looks like. Intensive outpatient, which includes our assertive community treatment team, our community support services team, which has the employment specialist, the housing, and our peers and our case managers. And then intensive outpatient SUD, that's alcohol and drug. And then wraparound and intensive IVHT for youth. So that's under the outpatient piece. And then aftercare recovery and support and services to remove barriers to community care. And if you want me to explain anything as I'm going along, just tell me that. The other thing that we have to do, and we have this, we have to have gero specialist services. So we do have a clinician whose role is half-time to provide various things. So she has a caseload, but she's also just sort of the older adult specialist. So she networks with APD. She's on the board at the senior center. She arranges trainings for providers in the community on working with older adults, that kind of thing. So that's a specific requirement. And then residential and housing supports, as I mentioned in our last meeting, we do have a program right now where we're able to help with rental assistance for individuals with severe and persistent mental illness. It doesn't look like that's going to be going away, so that's a good thing. And then we do have an exceptional needs care coordinator, so an ENCC. He's also my community support services supervisor. He's the person who understands all of the residential options in the state and the process with FOMAGIN to try to get people placed. We have notoriously had a very difficult time getting people into residential services, but it has happened once. So he knows the process and what to do. Behavioral health promotion and prevention lives with the county, so that's not one that we had to discuss. And then we do get a tiny bit of money for that's the block grant funded services. And so that I specifically put it can be for severe and persistent mental illness, adults or SUD folks, or youth with intense behavioral issues. And so we put that bit of money towards the youth part because there's so much funding for adults and not as much funding for youth. And so that helps to fund our skills trainer who primarily goes into the schools to work with kids that have behavioral issues while they're in the schools. And that tends to be where their acting out happens. And so she is in the school. And then that's that part. Then they want to know, how do you integrate peer support services? We have lots of peer support service, like we have a lot of peers. So we've got our peers on the adult team. We have we have a youth peer. Well, actually we don't anymore. She doesn't work for us anymore, but we're hiring for the youth peer position again. So if anybody knows anybody, youth peer, we're hiring. And then we have several recovery mentors. So we have a lot of peers, which they want us to have, so that's great. And then
what are the parameters for youth peer?
So it needs to be somebody who can be relatable to youth. So although, it's interesting, right? Because hiring practices, like, you can't discriminate, like when it comes to age, but obviously an older person working with a 14-year-old, that's not going to be as relatable as somebody younger. And they have to be at least 21 or our insurance won't cover them on the driving. So have to be at least 20. And they have to have their own lived experience. And actually we did hire, we do have a new peer on the adult team who is going to be working with a couple of the youth, but we still need another one who can take more of them. And then they just talk about, how do we ensure that we're going to do trauma-informed behavioral health services? So we just go into what that looks like here. So staff training and development, universal screening and assessment, safe therapeutic environment, client voice choice and collaboration, and organizational oversight and support. I go into what those things mean. If you would like for me to share, I can certainly do that. But we're only halfway through. Ensuring delivery of culturally and linguistically responsive and appropriate behavioral health services. So this goes into language assistance services, staff competency, community informed planning, and mitigating service disparities. We do not have any clinical staff that are bilingual. Unfortunately, we do have administrative staff who are, so that's helpful. But any individuals who are coming in for clinical services that do not speak English, we do have to use interpreter services, which is not ideal. We do offer higher pay for clinical folks who are bilingual, but we just don't get applicants. So hopefully one day.
Do you use phone, video? Do you bring people in?
No, so we use I think it's English to Spanish is what it's called.
Yeah.
Okay. So
you have folks in person.
I think they do it over the phone or with video. I think that's how that happens. And then care coordination and transition planning processes. So we have to talk about how we coordinate discharge from the state hospital. Community hospitals, residential treatment programs, and jails. So there's a blurb in here on how we do that, how we determine the most appropriate service provider, ensuring appropriate behavioral health referrals are made. It all comes out of the assessment, ensure that the clients are served in the least restrictive setting possible. And then engage in transition planning between levels of care. So I mean, all of this stuff is stuff we're already doing. We we essentially just had to like spell out exactly what it looks like. And then the whole next part is the community needs assessment. So this was actually really helpful because earlier this year, our hope is to become a CCBHC out here, which is, I'm gonna get it wrong. Community Behavioral Health Center.
Certified.
Yeah, that's what it is. Yes, Certified Community Behavioral Health Center. And so we're hoping to put that application in January. I can go more into that in a different meeting. All of that's by way of saying that we had to do a needs assessment as part of our initial sort of planning process to become a CCBHC. So we had already done a needs assessment, which was great. So I was able to put some of those things in here. And so they were wanting to know sort of what are the unmet needs that we identified in the needs assessment. And so some of the things that we identified is that some of the gaps are the sort of more the serving the Hispanics, Spanish speaking community, because it'd be nice to not to actually have providers who speak Spanish, veterans and geriatric population. And so what we identified was workforce vacancies are some of the problem, a shortage of qualified staff. And I talk about how the CMHP typically kind of becomes where all the new counselors go to get licensed, and then they go to private practice. And so we work with the most ill people in the community with the least experienced staff to do that. And how, one of the things that I would love to be able to do is for us to have higher wages so that we actually can hopefully try to have more experienced people. But we work with what we can. We do what we can. Reaching underserved and at-risk populations, those are the SPMI folks, children and transitional aged youth, unhoused individuals. Anyway, this was all just pulled from our needs assessment. The Latino community, older adults. The main thing that we talked about with the older adults was barriers such as transportation or mobility issues. And so it's hard for them to access like current like in clinic services. And so wanting to have somebody who can actually be mobile and go to those populations, that's one of the things I'd like to do. I'd like to have somebody specific for veterans. And then some other barriers were like awareness of services. Not everybody is necessarily aware of what we do. And then transportation, as we all know, is a huge problem in this county, where the med rides often cancel or are late or just don't show up. And then childcare for clients. Like we've had clients bring their kids to a group and we're like, I'm sorry, we can't, that's just not appropriate. So then I talk about, so how do we want to try to meet the needs for what we identified? And so then I go into, well, if we become a CCBHC, then we would get additional funding and then we could hopefully offer higher pay for those positions that we really would like to, like clinicians who might be licensed or have more experience, or the bilingual piece being able to offer even more for them. Having a veteran-specific clinician, a veteran-specific peer support specialist, a mobile mental health geriatric clinician. I would like a bilingual mental health clinician, a bilingual SUD clinician, and a bilingual peer support. This is my wish list, right? This is what I want. I would like to have what we're just going to call a transportation specialist who can drive people around. And then a mobile case manager to promote services in remote areas, because there's geographically, Crook County's huge, right? And so Post, Paulina, like we sent stuff out there, and I mean, those people are not coming into town for services, but it doesn't mean that people in those areas don't have that. So wanting some staff who can be mobile. And certified medical assistants to strengthen integration with primary care, a registered nurse. We do have a nurse on the ACT team, but I would like to have a nurse who's specific for all of our other clients too, because it's been so nice to have somebody who speaks that language with medical providers. And then I would like to have an LMFT who's specific, who can do family therapy. I mean, you get a brand new clinician out of school who's never done family therapy before and you're like, well, learn on the fly. That's how I did it. But I would like to have someone who is actually knows what they're doing. And then my ideal is that I actually would have a drop-in childcare provider on site so that parents could bring their kids. So when they have to go to group or they're going to a session, there's a 4-year-old running around the office while mom is trying to get therapy. So that's what I put as our, how do you plan to address it? And then planning activities related to stabilization center, which we don't have. There's a whole section on metrics. I'm not gonna bore you with that. I didn't print it out anyway. And then this is just what technical assistance do you need? So this all got submitted with our budget to OHA last week. It sounds like the first county to get feedback back, or at least that shared it with us, was Marion County. And so OHA said, thank you, we received your thing. And here's 3 pages of what you need to elaborate on. And so I imagine that that will happen me when they finally get around to ours. But that's what the plan is, if that helps. It's not really anything different than what we're doing, but how the money gets divvied out. And then the focus really being definitely those forensic populations. But everything that they're asking for, we already do. So there's nothing new. It's just a different way of thinking about it.
Any questions or observations?
It's just so much stuff. You guys do a lot of stuff here.
There's a lot of stuff, yes.
Yeah. Wow.
What's really fantastic though is that the previous contracts were almost 300 pages. The new contract is only about 60, so that's nice. Yeah.
That is nice.
Yeah. So I have a question about your Medicare population, both. I know that it's very, very, very limited in rural areas like this of people who will take the Medicare payment for those clients. Do you guys already have a program with that? Was that, I heard in there that you were talking about sending people to other houses, which would be absolutely amazing. Tech support for some of those people. I know like at Mosaic, we actually hire somebody who is telehealth only, and that's the only thing she does is see Medicare patients, and we have a waiting list. You know, so these people are on a waiting list to get on the recurrence of her, which won't happen for months. Was that one of the things in there?
So we are doing some mobile already with my clinician, who is half a clinician and then half sort of this specialist who has to do these other things that are not clinical, but that's all related to older adults. She does see some of her clients at their homes because of their difficulty coming in. And then I think that certainly, I mean, we do telehealth with some people, but we have also found that telehealth therapy doesn't work with the majority of the populations that we work with. And, you know, I mean, particularly kids, like trying to do telehealth with a 5-year-old or trying to do telehealth with a schizophrenic who is responding to internal stimuli. Well, you know, I mean, it just doesn't work. So we've sort of identified, you know, who are some people that really need like that, with the older adult population that need her to go out, but she's only a half-time clinician. So this is wanting to kind of have someone else whose sole job can be to go mobile and go around.
That'd be really cool.
So that's fingers crossed, that's my wish list.
Is it accurate that the only clinicians who can bill for
Medicare
are
license. So they allow LPC now, but the only people who are licensed here are myself and Kate. So my supervisor on the adult team, she will test, I think like in a month, and my manager on the Child and Family Services, she's testing in like a week or 2. So then I'll have 2 more people. obviously child and family, that's not gonna be Medicare. And then Amy, half her job is like supervising, so, you know, I mean, as much as we'll try to put the Medicare folks with her, she can't serve them all, and so then folks do sliding scale, or if they're, you know, or they might not have anything, in which case, what we've always done before is with the different service elements before, it was, okay, so we've got this bucket of money for people who are uninsured or underinsured. And so we can say, you know, Mary, who is 70 and has Medicare, and nobody here can bill for her, we can put her, and she's below, you know, the poverty guidelines or whatever it is, then we can put her over here underneath like this service element. So there's still the ability to do that. But like the majority of the ACT clients that we work with, at least half of them are Medicare because they're on disability. And so, like I said, Medicare doesn't cover the ACT code. And so even if we have a licensed provider providing that, Medicare isn't going to pay for that. And so then that's where, you know, this funding, right? I can say, well, we never got ACT money before, but great, let's take this chunk, $100,000 can be for ACT clients who we can bill for, but who absolutely need that level of outpatient care. Yeah.
Any questions or thoughts from folks online? Right. Our next couple of agenda items will actually relate to this plan. So I think we will be able to have additional discussion. The first, let's take a look at a state statute. It's ORS 43342. It is linked in the agenda, and will be linked in the minutes if you want to go revisit it. But that is when I do the introduction at the beginning of the meeting and say that this group is established in Oregon law. This is one of the statutes that calls for local government here in Crook County to pull this group together. So in addition to providing updates regarding our community mental health providers to our board of commissioners, we are also the local planning committee for alcohol and drug prevention and treatment services. So there's a little bit of overlap with supporting our CMHP and that prevention piece, which, as Angela mentioned, lives with public health. Majority of it right now, as far as funding or the work that we do that meets those requirements. So this group is has voice into what those services look like. And we don't necessarily have prevention related a prevention related goal in our work plan. So we do have a review of our work plan that we're currently doing. And so hopefully we can think about what we want to have happen in that prevention space. And then we have several work plans through public health that get submitted to Oregon Health Authority that say what we're wanting to do with certain funds. Our funds are still siloed into program elements. They were service elements in the behavioral health world, but we do have some siloing of funds. Our tobacco prevention program is very much a siloed pot of money, and we have a specific tobacco prevention and education program work plan. So my sense is that it would be helpful for this group to know what prevention services are already planned in the community. And once that information is shared with you, that we can get some feedback on, these are live plans. I mean, there are some things that we have to provide, but these are plans that we can amend based on need in our local community. So like my hope and Stephanie as the supervisor for the prevention and health promotion teams is that we can get feedback from you all and then either shape or reshape our plans to better meet local need. And you all hopefully can help us with that. So if you want to dig into those weeds, like I said, the statute is in the agenda, it will be in the meeting minutes, and then I think it'll be something that we'll come back to when we review our group work plan. Which is next on the agenda. So the work plan, I'm looking at the terminology we use, goal. So our big buckets right now are staffing of our health system, then health systems coordination. And then is there a second bucket? And the third is that accountability piece and like helping speak into services and plans that are being offered locally. So I think that's in that accountability bucket is probably where we'll land with this prevention piece. But we'll have a deeper dive into that conversation once we get an overview presented to you all of the services that are already planned and available. So right now, in our accountability bucket, we've said that we want all of our appointed members to understand the metrics that Best Care is responsible for. And as we heard here, there's a lot of metrics. So much so that Angela didn't print them off or share them specifically.
Well, yeah, and I can bring that next time, because we actually created this handy little grid.
We can even put it in the meeting minutes to send out after, because I stopped taking note after like bullet 12. If I'm being completely honest, I was like, I'm just gonna ask Angela to send it to me.
Get a summary.
Yes.
Yeah, and just remember, it's a draft.
And that's okay. We can put that as long as it can be shared.
Yeah.
We can let everyone know
Yeah.
if they have questions to reach out.
Yeah.
And so maybe that I was gonna pose the question is, how do we do that? If there are, I don't know how many metrics, what makes sense for this group to have the capacity to help you review, to troubleshoot metrics? What role does this group want to have in performance metrics? How can we best be supportive? I think is the question. When we kind of broke out activities, we said we would like to have overview presentations from Best Care, and we've gotten those pretty consistently. Angela's reported out on specific service elements over our past several meetings, and we just got a huge overview. So if that's helpful, maybe we can set a cadence of those updates, and maybe they're core service updates now. I don't know how we do that or what would be most helpful from the group. But if there's any ideas on how we meet this goal of all of our appointed council members have an understanding of the services that our CMHP provides and how we are doing in meeting metrics for those services. Is there anything specific that folks want to know? In addition to maybe seeing a metric that chart of metrics.
I'm gonna get a quick. I don't even remember what's on there.
So in addition to that, is there anything else that would be helpful for us to be able to best support Best Care in meeting? Writing this, writing and meeting metrics. You want it if you have additional ideas,
I'm just not
see your
sure,
wheels turn.
without, I doubt they're turning. I'm just not sure without knowing exactly what the metrics are,
Yes.
how we could help, but. Cause I think once we know what the metrics are, we'll know how much we already know. Like, I don't know what I don't know.
Yeah.
I can tell you that, I do think we play a role in helping the community and Best Care
Like right now, I feel invested in knowing if they get this money and they do all this, just by her presentation,
Right.
I feel like
Mhm.
I wanna know. I need her to
Mhm.
message us before if she finds out.
As soon as you know.
Yeah.
Like I wouldn't have known about the wrap. The piece that they hold if I didn't work at the school, and know that they help, children, cause those are pieces that I would have never known. I thought it was only things that they did, as far as like alcoholic treatments like that, for those kind of things. I didn't know that they helped also the kids that needed help as well. Just because they were having behaviors and things like that, so they did a lot more.
Really big, I don't know how we can all know everything, but if we broke off pieces, if each one of us took a couple, like, brainstorm.
Or even if Angela let us know, especially with this new system, what areas she thinks she needs help in most. And then maybe now that we are having meetings regularly again after the kerfuffle of this year's everything, just all the things public meeting related, if maybe every meeting she presents on a chunk of them, right? Instead of giving us that whole overview once a year, it's here's 4 of the core elements. Let's talk about these a little more in depth at this meeting. And then if people have stuff they can input, and then at the next meeting, she does another 4. I don't know if that would be helpful.
Hand raise.
Yes, Courtney or Kim.
Hey, this is Kimberly. What would be helpful? We're here Googling acronyms because we don't know what they mean. And I know it sounds really stupid, but I think there were a lot of acronyms thrown out. And so maybe if we saw the metrics, but also understood what the acronyms mean, I want to say dumb it down just a little bit for us.
I think you're saying what we're all feeling,
Okay, okay.
most of us.
We actually have an acronyms list, that we give to all our new staff. I could give it to this group.
If we could include that with
Okay.
the, yeah.
Thank you.
Thank you, Kimberly.
Alex, to your, point or suggestion, I think historically we have, instead of looking at all the metrics, right? We've looked at the ones that are like, we're struggling to meet this, or we would like to meet this more thoroughly. And so those are the ones that this group has dug into historically, but also it's up to this group to decide what you all, how you want to support this process. So we will add the chart of metrics for the plan. And I think we can work with Angela, our staff, kind of behind the scenes in the meantime, can bring a proposal back to you all of here are some options for how we do this chunk of work. I see Emily had something in the chat. Alex, can you share that with the group, or if Emily wants to come off,
Emily said, I think it would be helpful if we could know the overall numbers of usage in those different programs. I would imagine some treatment evaluations are done regularly, and we could see what the outcomes of those evaluations are to see what areas we could be of use in. Is that big enough for you to see, Angela?
Yeah,
Okay.
so yeah, we can run numbers. I mean, we have access to more data than we've ever had being in Epic now. It's just not always fully accurate because I mean, ACT is easy because I can ask the ACT team, how many ACT clients do you have? I think they're at like 14 or 15 ACT clients, something like that. But we have hundreds of adults that we serve in outpatient, and we have hundreds of youth that we serve, and we have hundreds of SUD folks. So, but in those specialized programs, you're only talking about like a handful of people. So, like I said, we've had one PSRB person in 5 years. Over all of these years, we've done, like I said, we're at 64 civil commitment investigations this year so far. But I think we've only gone to trial once this year. And so there might be like, this is how many investigations get started, but there's only one, and right now there is nobody civilly committed in Crook County. And so when there's usually is one, maybe two. I think there was one point in time we had two at the same time. So it would like, would you want to know numbers of sort of like who all we're serving, or the numbers of the people in these specialized programs? Like aid and assist, we only ever have one or two at a time generally. So it'd be more of like what numbers.
I think she just means whatever would make it, whatever numbers that we could be helpful to.
Whatever would help us help you best.
Yeah.
So maybe
But
that's
that's
again
not an
something that
area
we
that's gonna
can kind of
happen
talk
every
about before the next meeting to,
Yeah, I think we'll do some behind the scenes work
Okay.
to come up with some options to bring back in December, and we can land on how we wanna chew on this elephant.
But you know, if you guys wanted to know, for example, you know, in this quarter, how many individuals did you see in crisis, and sort of what was the outcome? You know, were they, you know, referred to a higher level of care? Were they safety planned in the community? I mean, we have to track all of that and send all of that to OHA, so we have those numbers. But aid and assist, civil commitment, IIDHT, which we don't have anybody in right now, ACT, I mean, all of those are just gonna be smaller numbers because those are, you know, those are the most severity, right? But we have hundreds of clients.
One of the activities in this bucket is creating a flow chart for crisis for non-medically trained people. This was an activity that was developed prior to probably most of us being appointed. And so I'm not sure if that's something that that this group still wants or needs. It wasn't something that we had developed. We hadn't gotten to that piece of our work plan before now. But at the time, I think that was a couple years ago, the group was really wanting to better understand how crisis responds and in what situations and in what spaces, whether it's the library lobby or what it is. I'm not totally sure what, I can't remember. We might have to do some digging in minutes to find that out. But is that striking anyone as a need to better understand or helping the community better understand crisis services?
I know a lot of times when I teach, not like I've taught a lot, but the few times I've taught QPR classes,
Which acronym stands for?
question, persuade, and refer, which is a suicide prevention training. A lot of people, you know, we bring up 988, which is the National Suicide and Crisis Lifeline. A lot of people are concerned with, well, when I call them, will 911 come? Like, a lot of people don't want 911 to be there. And then they ask what the process is, you know, in what situation will the crisis team come? When do I just get transferred to talk to someone on the phone? Will they put me in a stabilization center? A lot of people are curious about that flow. So I can only speak to that from a lot of lay people in the community that are looking at that as an option or have family or friends that they want to refer that option to, and they're worried that people won't do it because they don't know what's going to happen. So.
And one of the things was on my mind that I had mentioned was the suicide prevention, and it just looking at what's happening, you know, it ebbs and flows, peaks and stuff in the community, and we're kind of coming down off of a peak that in the area that I see, which could not be the area that everybody sees, so I will acknowledge that I could be totally wrong in that. But I started thinking about that and how how we could help churches and different places where people are going to go to in the middle of a crisis when they don't want to go to a medical facility. Do they have the QPR training? How do we further educate what the resources are without handing a pamphlet? I did at my work have a pastor's wife come and she's like, hey, they're asking me all these questions and I don't know what to do. You know, I handed her all the resources that we had, but felt really kind of icky about it. Send them to you, okay. Kind of felt icky about it because I felt like it was a miss. Like, does everybody read all of the pamphlet and understand it? There needed to be more of a, and that's what made me think, are we missing something here in different places that we can be touching people in the non-medical community?
Well, that, I don't know, maybe connects to the needs assessment, wasn't one of the things, like, people don't know the services that are offered.
Yeah, so, yes, that
Right.
was some of the feedback.
So I flagged that as well, it's like, how can we, maybe that is something that we can lean into and, figure out how we can better increase awareness of services that are available, resources. We do, and Alex, have a suicide prevention and your titles really, suicide prevention, mental health promotion.
Mental health promotion and suicide prevention and postvention.
Thank you. Meaning that spectrum of services needed related to crisis, there's the suicide prevention piece, that upstream, the intervention piece, the community readiness, and then referring to services, and then in the event of a suicide death, that follow-up to prevent contagion, so follow-up with family members in school settings, if it happens to be a school-aged individual. So we have that resource here in the community. And again, I think there is a lack of knowledge that even is, Alex is a resource for us in that space. And in partnership with other providers in the community, I think that's really key too, is Best Care as a CMHP, right, is serving really high acuity, that's primary population
for sure.
that you are tasked with, required to serve. And we all know that there's a spectrum of mental health issues that pop up in our community. And so how do we make sure that there's hopefully something for everyone if and when they need it. I would love to have more question, persuade, refer, that suicide, equipping community members, lay folks, no mental health background, no medical background, be able to have a discussion with someone who's in crisis and help link them to resources. But there's a lot that goes to the QPR is a fairly quick introduction. It's very, very introductory, but there are other trainings that are available and things that we can do as a community to better equip all of us to do this work. See, Emily.
She was just saying that what we were talking about was right, but her microphone's not working.
Okay. Okay.
Is it working now?
Yes, it is.
Perfect. Sorry, I didn't mean to interrupt. I actually am going to be starting working on something very like akin to what we're talking about. I responded to an individual in crisis at the library, and after that, an employee from the library reached out to me and asked if I could come and teach some of the staff members better ways of how to help somebody when they're experiencing crisis, or like what they should do, you know, if the person is becoming violent, you know, whatever that looks like. And I actually watched a presentation that Portland Police Bureau was putting on, that they go out into the community. They have a whole unit that goes out and teaches classes to community members in different churches, businesses, whatnot, on, hey, if you see somebody in crisis, this is what you can do to help them. These are the resources you might be able to offer them, that kind of stuff. So I am actually going to start working on something like that for Crook County.
Love that.
Thank you, Emily.
Emily, if you want crisis to help with that, just reach out to Kate, because for sure we are happy to help partner with that.
Yes, I have a meeting with Kate tomorrow, so I was going to mention it to her.
Me too, Emily.
Yes.
Excellent. Alex, do you have, so I think with the work plan, one of the things that we'll want to think about is how do we maybe update some of our activities to meet our objectives, and so we can work on drafting some of those options and bring back in the December meeting. So if you have any ideas of things that you would like to add to the work plan is linked in all of our agendas. I think they get linked in, it gets linked in the meeting minutes as well. On the back end, we'll have our staff draft up some activities, and you all can decide if they hit the mark or not in our next meeting. So April, you had mentioned that like the level of mental health issues that you're seeing in the clinical setting. Alex, do you have some community stats for that?
For suicide ideology? Yes. So I actually just recently, in the last few weeks, got access to a data tracking system through the state called Essence. And unfortunately, only St. Charles has data on there because you have to go, only emergency departments can submit information on there. So Mosaic can't. I tried. But there's actually, so it bases off of previous data over the years, and it'll kind of give you on a daily, weekly, monthly, quarterly, or yearly spread. And I think I have most of them set up daily. A projected number of suicide attempts and suicide ideology of what it would expect based on the past, and then what actually happens. And there was a good week in September where it was kind of in the warning zone and high alert zone of higher than it would be expected for Crook County. So you're not wrong. It's there.
Yeah, like there's a stigma, like somebody answered, let me see, 2 9 answered yes to number 9, if they've thought or want to harm themselves. And I watch even medical professionals be like, oh my gosh, and I'm like, guys, like, nobody's gonna talk to you if you act like that. Like this has to become something that we can all talk about. This has to be something that we've normalized enough that anybody can talk to anybody about it and not be afraid of, we're gonna say the wrong thing. We're not going to say anything. Just give them the 988 number. I was like, no, that's not the answer. We do not give the 988 number if we have a clinician on site right now. We have 2 to 3 patients a day that we are screening and doing a safety plan with. I mean, it's just, that's the norm. So I do think it's something that.
Do the providers ask them, like, are you in counseling, or have you thought about counseling?
Yeah, it's part of our KPI, either that we have to follow through, we have to do Columbia, do a safety plan, and then if they're engaged in therapy or follow crisis team, we get them to St. Charles in the emergency room. I do that a couple times. Sometimes they just come to the front desk. One lady came to the front desk and she wasn't a patient, and then she took off. Pulled the front desk person, 24 herself, took off. They were running out after her in the street, but they didn't find her. And then, of course, the girls are like, I looked on Facebook. She's still missing. I'm like, you guys, I'm so sorry. I mean, so it was a miss. I'm like, at least give her the national hotline number if she's not a patient and she was not willing to stay. If there's only so much you can do, but I mean, it's like having that conversation. They're like, oh, I didn't even think about that. And it's like making sure that you have some tools on your tool belt to help you at least help somebody get to someone that can do something.
I will say one thing you can do is ask me to come to a QPR training for your staff. If nothing else, it teaches them how to talk to someone in that situation. And the other thing for more of the clinicians or nurses that are actually with the patients interpreting the questionnaires they're doing for that is making sure they have trauma-informed training to learn how to talk to someone about it better. And if you need help finding some of those classes, I can help you because there are a ton of them. Yeah.
Wonder if any of them, I mean, we can keep an eye out on ones that would offer CEUs too.
Yeah, and I get emails from OHA monthly and sometimes even more often, that have lists of upcoming trainings, and they say if they're CEUs or not. I send them to the schools, but I can start sending them to you guys too. I didn't even think about that.
Courtney has her hand up.
Yes, Courtney or Kimberly.
Hey, this is Kimberly. Just a question. It was mentioned that emergency departments are the only ones that could submit data. Is St. Charles, Prineville submitting data?
Yes.
They are. Okay.
Yes.
That's all I need to know. And then, we recognize as a health system that we do see an uptick in suicide attempts in September when school starts. That is just something that we've been seeing, unfortunately. So, but I'm being told that that's a regular thing. Unfortunately, it's an annual thing. So
Yeah.
I don't know.
The thing about Essence is it takes all that into consideration. So even with that, this year has been higher than it anticipated.
Gotcha. Okay. Thank you for that.
You're welcome.
Another thing that came up in the community needs assessment, and then in April, you were talking about it as well, is the transportation piece. So I wonder, we have about 6 minutes. It's all, I wanna respect everyone's time, but would you like to introduce the issue? Maybe if you have a little more in-depth information, or April, if you want to speak to any specific issues that you're experiencing around medical transportation, and then we can maybe bump it to have a dedicated space on the agenda in the summer.
Well, what we're seeing is that it's extremely unreliable, and that sometimes clients are getting canceled at the last minute, or we've got some folks that that maybe live way out, and then they say, well, we can't come to your road, but if you can walk down your road. I mean, I'm thinking of this one guy, they were making him go 3 miles from his house. We'll meet you at this corner. Well, he's like in a wheelchair or something. I mean, like, that's
Who
not,
are the providers that? Is it like
it's just the number. If you have OHP, it's.
the OHP specific
Yeah.
service?
So OHP will pay for it. We're seeing an uptick in like Medicare people just can't afford it. The insurance doesn't cover it. Mosaic is covering as much as they can. This year alone, we've already spent 36,000 in Prineville to transport people to doctor's appointments. Because there's only one company that we're actually contracted with, because there's only one company, medical transport company in Prineville, really. We don't have medical Ubers. We've like we do in Bend and Redmond that are much less expensive. But I mean, this is just a small portion of maybe even a larger problem. Is even John Day is better serviced with specialists and stuff that will come and set up an office even 1 or 2 days a week. Why can't we get our specialists here more so our patients don't have to go all the way to Bend or Redmond? I mean, some people just flat out won't go. It's just way too far, or they don't have family members that can take them. We're doing gas cards, we're doing what we can to help offload it, but I don't know, we don't have anything here, even a taxi isn't even really good.
So as part of, or one of the bigger things that you're noticing is transport from Crook County to Deschutes for specialist care.
Yeah,
It's not necessarily like transport within Crook County.
well, anybody
Although that's
off the
hard
grid,
too.
off the road, it's that Juniper Canyon or something, and it's a dirt road, yeah, they flat out either won't go, or they're gonna charge you $50 more to go out there. Our patients can't afford that. Even
What?
the clinic in town.
Who's the only company you're contracted with?
It's Tonya.
There is, so for veteran specific transport, Central Oregon Intergovernmental Council does have a line that veterans can call and get transportation to medical appointments. They have to pre-schedule it. But that could be a resource for folks. The county veteran service office can help set that up too.
It's TBS.
TBR. Thank you.
We're trying to negotiate costs, but.
Well, and our peers and our case managers do type pick people up and take people, and we've taken people to surgeries and spent all day with them in Bend getting a surgery and bringing them back. But all that time is not paid for. But it's like, if we don't do it, like, there's nobody to do it. You know, or we've got some clients who live like out, you know, by the big reservoir. And I mean, that's an hour outside of town, and we go out there and pick them up and bring them in, and then we take them back, and then, I mean, there's half a day spent transporting, and that's not. I mean, we can't bill 4 hours of peer support for.
And I don't know if this is still a thing, but I know like 3 or 4 years ago, there was this one lady in particular out Juniper Canyon that whenever she couldn't get a ride to something, she would fake an injury and call 911 and have the ambulance come pick her up and bring her into town so that she could have easy access to getting to stuff because she didn't have a way to get. I don't know if she still does it. I don't know if other people do it, but I had a friend who was her neighbor and it was apparently a big problem. So
Also illegal.
yeah. Yeah, they caught on, but I mean, what are they supposed to do?
Right.
She'd sometimes like lay out in the road, like she got hit by a car and just lay there and they come pick her up. And yeah, so it happens.
Are there, again, I wanna be respectful of time, are there agenda items that you all wanna make, any new agenda items that you want us to add to the December meeting? I have a feeling we're gonna be revisiting a lot of this, but is there anything that you wanna see come up in December? We'll send out an ask. Alex will send out an ask as well, if you don't have anything pressing.
I'm sure by then I will.
April will
been
think of
going
something
back
as soon as the meeting's adjourned.
to This, so I'm sure that this will be final by then.
Alright. Thank you, Erica. I think we're out, it's 1:00.
Yeah.
So, we'll put a bow on this and adjourn. Our next meeting is December 1st.
If anyone wants more free food, go to St. Charles.
And speaking of that, I have that we're at St. Charles next time.
Okay.
Oh, they were expecting us?
Oh,
Yeah. I somehow, I don't know, I had you guys on my calendar, but I must have told them we were going. I don't know. I feel
We'll
horrible.
make sure we communicate out location, for December 1st. Thank you all for your time and your energy.